What if I told you there is a fluid in the human body that can literally change its microscopic structure from an impenetrable acidic brick wall into, well, into like a welcoming biological superhighway in just a matter of a few days?
I mean, it sounds completely like science fiction
Yeah.
or, some kind of highly classified military defense system,
Right.
but it's actually happening inside the human body constantly.
Yeah, so welcome to our deep dive. We are really glad you're here with us today because our mission is to decode a highly sophisticated, deeply misunderstood, and honestly ever-changing biological substance. Yeah. We're talking about cervical mucus.
Exactly. And the core reality we're exploring today is that the natural composition of cervical mucus changes throughout your cycle, your lifetime, and even under a microscope.
Yeah, it is not just some static fluid at all. It's this highly responsive communication and defense system happening right inside you.
And we have a really brilliant stack of sources guiding us today to help decode all of this. We are synthesizing clinical guidelines from the BMJ best practice and the AUA guideline.
Which are super comprehensive.
Very. Plus, we're analyzing fertility tracking data from Clue and looking at some truly groundbreaking microscopic research that was recently highlighted by Science Friday.
Awesome. And we are going to avoid the heavy medical jargon, right? We just want to get straight into the mechanics of how this all actually works. Okay, let's unpack this. Because before we can even talk about how this substance changes, we really need to establish what it's doing on a normal Tuesday.
Right, the baseline.
Exactly, because when it is not actively trying to help you get pregnant, this fluid is doing some really heavy lifting just to keep the vaginal ecosystem healthy.
It is. Baseline vaginal discharge is an incredibly active self-cleaning mechanism.
Sure.
Most people think of it simply as moisture, but it's a really complex mixture. You have water, of course, but you also have microorganisms and what we call desquamated cells.
Which are what, exactly?
Oh, they're just the dead cells constantly shedding from the vaginal walls. It's very much like how your outer skin sheds.
Okay, I mean, I'm trying to picture the consistency, though, because water and skin cells, they don't naturally create that distinct, sometimes jelly-like texture that people actually experience.
Yeah.
There has to be like a structural element holding it all together, doesn't there?
What's fascinating here is the underlying architecture. So the jelly-like consistency actually comes down to these long, stringy molecules called mucins.
Mucins. Okay.
Yeah, and the biochemist Katharina Ribbeck, she leads a research group at MIT. She has a wonderful way of describing this. She says you can picture these mucins like a giant pot of spaghetti.
Oh, wow. A microscopic pot of spaghetti.
Yes. So in a baseline state, those mucin spaghetti strands, they entangle with one another to build a complex, dense, sponge-like network.
A sponge.
Exactly.
Right.
But that physical sponge is really only half the story. The other half is the intense chemical warfare happening inside that sponge to keep you safe.
Wait, tell me about the chemical warfare part, because reading through the BMJ best practice guidelines, there is a lot of discussion about the acid mantle. So how does a pot of spaghetti become an acid mantle?
Well, it starts with those shedding skin cells we just mentioned. In a healthy reproductive aged vagina, the superficial epithelial cells, the ones lining the wall, are constantly renewing.
Okay.
And when they shed, they burst open and release large amounts of a sugar called glycogen.
Oh, so they are essentially dropping a food source right into the environment?
A massive food source. And this glycogen is basically an all-you-can-eat buffet for the good bacteria natives to the vagina, primarily a family called lactobacilli.
Right. I've heard of lactobacilli.
Yeah, so the lactobacilli gorge on this glycogen. And as a byproduct of digesting it, they produce lactic acid and hydrogen peroxide.
Wait, hydrogen peroxide? Like the stuff in the brown bottle you pour on a cut?
The very same compound, yes.
That is wild.
It is. And by pumping out lactic acid and hydrogen peroxide, these good bacteria keep the normal vaginal pH sitting somewhere between a 3.8 and 4.5.
Which is pretty acidic, right?
Highly acidic. To put that in perspective, a pH of 7 is neutral, like pure water. A pH of 3.8 is approaching the acidity of a tomato or even like a weak vinegar.
Okay, I have an image for this. It is like the uterus is an incredibly exclusive VIP club.
Yeah.
And this baseline mucus is the bouncer at the door.
I like that.
Right. It's not just a passive fluid, but a highly trained bouncer using this dense hydrogen peroxide-laced sponge to create a totally hostile environment, keeping any external pathogens or, unwanted bacteria from getting past the velvet rope.
That is a perfect visualization. It's a primary immune defense. The acidic pH physically damages the cell walls of harmful microbes.
Wow.
Yeah, it basically prevents infections from ever taking over the ecosystem.
I mean, I see how that protects the body on a daily basis,
Right.
but it creates a massive logical problem.
How so?
Well, if this bouncer is so incredibly strict and the environment is a literal acid bath, how does a pregnancy ever happen? Because biologically speaking, sperm are technically outside invaders, too.
That is true.
So if they hit an acid bath, they aren't going to survive the swim to the egg.
They absolutely would not survive.
Yeah.
And that brings us to the brilliance of the menstrual cycle. If the baseline mucus is a strict bouncer, then for a few very specific days a month, under the influence of hormones, the entry rules completely rewrite themselves.
Right, because the natural composition of cervical mucus changes throughout your cycle.
Exactly.
It is like a chemical symphony, and the conductors are estrogen and progesterone, constantly in this push and pull dynamic.
Let's track that dynamic through a standard cycle.
Yeah.
So right after your period finishes, estrogen and progesterone are both relatively low.
Okay.
Because of this, fluid production drops significantly. You might experience what the clinical tracking guidelines simply call dry days.
And as the body gears up to release an egg, I'm guessing that changes?
Radically. As a follicle develops in the ovary, it starts pumping out estrogen. And as estrogen rises, the discharge shifts.
Getting
Yes. According to the clue tracking data in the UNC School of Medicine guidelines, you enter a transitional phase, type 3 mucus. The discharge becomes thick, creamy, and maybe a bit sticky. It often looks whitish or yellowish.
So the bouncer is maybe unlocking the door, but not quite opening it yet.
That's a good way to put it.
But then we hit the main event, right? Ovulation. What happens to the fluid when the egg is actually about to drop?
Estrogen reaches its absolute peak about 1 to 2 days before ovulation. And in response, the mucus completely transforms into type 4.
What does type 4 look like?
The dense spaghetti network loosens up. The fluid becomes clear, highly stretchy, liquid, and slippery. It is very commonly compared to the consistency of raw egg whites.
The raw egg white phase. But wait, if the texture is changing, does the chemistry change too? Like, does it stay acidic?
It does not. The ovulatory mucus actually becomes alkaline.
Oh, wow.
Yeah, the pH shifts to become incredibly welcoming and nourishing to sperm. It acts as a transport medium, providing nutrients and physical channels for the sperm to swim swiftly toward the cervix.
I am stuck on the timing here, though. If an unfertilized egg only lives for a very short window, like 24 hours tops, why does this fluid change and stay alkaline for several days?
That's a great question.
Isn't that leaving the door open for harmful pathogens for way too long? Why the mismatch in timing?
If we connect this to the bigger picture, you have to look at the survival capabilities of the other biological player, which is the sperm.
Okay.
While the egg is only viable for up to 24 hours, sperm can survive in the female reproductive tract for up to 7 days, though it's usually closer to 3 to 5 days.
Oh, I see. So the sperm can basically arrive early, hang out in the safe haven, and wait for the egg to show up.
Precisely. But they can only survive that long because they are protected and nourished by that highly fertile, alkaline egg white mucus.
That is amazing.
It is an evolutionary workaround for a very narrow fertilization window.
Mhm.
And the moment ovulation is over, the corpus luteum, which is the empty follicle left behind by the egg, starts producing progesterone. And progesterone suppresses estrogen.
And what does progesterone do to our bouncer?
It slams the door shut. Under the influence of progesterones, the mucus instantly reverts to being thick, sticky, dense, and acidic again. The superhighway is dismantled.
You know, if this chemical transformation is so incredibly precise and predictable, it makes you wonder, can a person actually use these physical signs in real time to control their fertility?
They can, and many do. The clinical data on fertility awareness methods, or FAM, is robust when practiced strictly.
Which method specifically?
Well, one of the primary methods is the cervical mucus method, which requires tracking the secretions every single day.
How does that work practically? Do you just look for that egg white consistency?
You are monitoring for the peak day. In clinical terms, the peak day is defined as the absolute last day that you observe that clear, stretchy, wet mucus.
Wait, but you can only really know it was the peak day in hindsight.
Correct.
Like you'd have to wake up the next day, see that the mucus went back to being sticky and thick to confirm that yesterday was the peak.
That is the exact challenge, which is why the clinical guidelines are so strict.
Yeah.
If you're using this method to avoid pregnancy, you have to consider yourself highly fertile from the very first sign of any secretions after your period.
Oh, wow.
Yeah. And you must avoid unprotected sex until 4 full days after you've confirmed that peak day.
4 full days after the change, back to sticky. That is a really significant window of time.
It is, which
Yeah.
is why the symptothermal method is considered much more reliable. It takes the mucus tracking and adds another layer of data, which is basal body temperature, or BBT.
I have heard of BBT. That's taking your temperature first thing in the morning before you even sit up in bed, right?
Exactly.
But what is the biological mechanism there? Why would your body temperature care if you've ovulated?
It all traces back to progesterone.
Oh, really?
Yeah. When that empty follicle starts pumping out progesterone post-ovulation, the hormone travels to the hypothalamus in the brain, which basically acts as your body's internal thermostat. Progesterone has a thermogenic effect. It literally turns the dial up, causing your resting body temperature to spike by about 0.9 degrees Fahrenheit, or half a degree Celsius.
So you track the stretching mucus to know when the window opens, and then you watch for the temperature spike to prove the window has closed.
Yes, and the medical guidelines note that if a couple only has unprotected sex in the post-ovulatory phase, meaning they wait until after that temperature has stayed high for 3 consecutive days, the failure rate is incredibly low, around just 6.6%.
Here's where it gets really interesting, though.
Oh,
Because as I was reading the UNC School of Medicine guide, it hit me that tracking this fluid cannot be as simple as it sounds on paper. The vagina is a busy environment.
very true.
So if you are tracking for wetness and stretch,
Yeah.
how do you differentiate between cervical mucus and other fluids like arousal fluid or seminal fluid?
It is a critical hurdle for anyone relying on these methods.
Mm-hmm.
Arousal fluid is essentially filtered blood plasma that the body pushes through the vaginal walls during sexual stimulation to provide lubrication.
And it feels the same.
It's very wet and slippery, so it mimics fertile mucus. And seminal fluid from a male partner also becomes watery about 20 to 30 minutes after intercourse.
So they literally all feel the same on your fingers. How do you tell the difference?
The clinical advice relies on the wait-and-see rule, based on how the body processes these different fluids over time.
Okay, so how long do you wait?
Well, arousal fluid dissipates very quickly when stimulation ends, usually within about an hour, as it gets reabsorbed.
And the seminal fluid?
It takes longer, but most of it will naturally exit the vagina within 12 to 14 hours. So if you are uncertain about what you're observing, the rule is to wait.
Just wait it out.
Right, wait an hour to see if the slippery sensation was just arousal fluid, or wait up to 14 hours after intercourse to ensure the seminal fluid has cleared before you make a definitive observation for your fertility chart.
That is incredibly practical, actionable advice. So we know what this mucus feels like, and we know how it interacts with hormones to change our body temperature, but I want to zoom in even closer.
Okay, let's do it.
What does this fluid actually look like on a microscopic level?
This is where we shift from chemistry to stunning biological architecture. The microscopic structures of cervical mucus are an absolute marvel.
The Science Friday article highlighted some images of this, and the visual completely blew my mind.
It's beautiful, isn't it?
It really is. The researchers take a sample of that highly fertile ovulatory mucus, the stuff surging with estrogen, they smear it on a glass slide and just let it air dry, and it undergoes a process called ferning.
Right, ferning. When the estrogen-rich mucus dries, the salts and proteins within it physically crystallize into intricate, branching, leaf-like fern structures.
It literally looks like a frost pattern creeping across a winter window pane.
Yes, exactly.
Pillar Vigil, an OBGYN, described it like a moonlit kelp garden. It is as if your body is building a microscopic lattice or trellis when you are fertile. It creates these orderly, open, geometric pathways for the sperm to swim right through.
And just as remarkably, once ovulation is over and the progesterone kicks in, those beautiful fern patterns completely disappear from the slides.
They just vanish.
Yep. The body dismantles the trellis, replacing it with a disorganized, dense mesh that sperm simply cannot navigate.
Okay, so if the cycle is this constant opening and closing of the gates, building and destroying the trellis, what happens when a pregnancy actually takes hold? Does the cycle just freeze on the closed setting for 9 months?
It goes far beyond simply freezing on the closed setting. During pregnancy, the composition changes drastically again to form the cervical mucus plug.
The mucus plug?
Right. It becomes the thickest, most impenetrable barrier possible. As Katharina Ribbeck from MIT points out, a developing fetus doesn't have skin yet.
Oh, that's true.
So the cervical mucus plug is the primary physical and chemical barrier separating the highly sterile, vulnerable environment of the uterus from the bacteria-rich outside world.
It is the ultimate shield. But what happens if that shield has a weak spot?
Well, if the barrier fails, pathogens can slip through the cervix and infect the amniotic fluid or the uterine lining, and this is a massive clinical issue.
Oh, mess.
Ribbeck's research highlights that a staggering 25 to 40% of early preterm births are believed to be caused by these kinds of microbial infections.
Wow. And this is where the MIT study comes in, right? How did they actually test this? Like, how do you figure out if a mucus plug is failing before a patient goes into early labor?
Ribbeck's team took samples of cervical mucus from patients who were deemed at a high risk for preterm labor, as well as samples from low-risk pregnancies.
Okay.
In the lab, they exposed these mucus samples to fluorescently labeled particles and actual bacteria to measure the permeability. They basically watched to see how easily the invaders could swim through the gel.
And what did they find in the high-risk patients?
They found that the mucus from patients at high risk for preterm labor was highly permeable. Structurally, it wasn't acting like the dense, impregnable pregnancy barrier it should have been.
Oh, no.
Yeah, instead, it was mimicking the open, permeable structure of ovulatory mucus.
So the trellis was left up, the gates were left open.
Exactly. And because it was physically looser, it created a structural window of opportunity for pathogens to pass through, trigger an inflammatory response, and ultimately induce early labor.
That is terrifying, but also incredibly promising. Because if we understand the mechanics of that failure, could we one day use this? Like, could an OBGYN take a tiny swab of mucus at, say, 12 weeks pregnant, look at it under a microscope, see that it's too permeable, and intervene to prevent preterm labor before it even starts?
This raises an important question for the future of obstetrics. Using mucus as a predictive diagnostic tool, rather than just waiting for symptoms of early labor to appear, well, it could completely revolutionize how we monitor high-risk pregnancies.
It really emphasizes how deeply responsive this tissue is to its environment. But that level of responsiveness means it is also highly sensitive to the overall timeline of your life.
Absolutely.
We've explored the baseline, the cycle, and the lockdown of pregnancy. But what happens to this dynamic system when the hormone factory starts shutting down?
You're referring to the menopause transition.
Yes. If high estrogen is what creates that beautiful ferning structure and what fuels the thick pregnancy barriers and what drops the glycogen to feed the good bacteria, what happens when the estrogen levels permanently drop later in life?
The drop in estrogen causes a profound shift in the entire vaginal ecosystem. It leads to a condition clinically known as genitourinary syndrome of menopause, or GSM.
Walk me through the physiological cascade of that. What actually happens to the tissue?
Well, when estrogen plummets, the vaginal mucosa, the cellular lining, physically thins out. Because those superficial cells aren't turning over and shedding the way they used to, they stop releasing glycogen.
The food source vanishes.
The buffet is closed. And without glycogen, the good lactobacilli bacteria starve.
Oh, wow.
Yeah, and without the lactobacilli producing lactic acid and hydrogen peroxide, the vaginal pH rises. It shifts from that healthy, highly acidic 3.8 up to a pH above 5.
So the acidic bouncer has officially left the building.
Pretty much. And when the pH becomes less acidic, it allows other, less desirable bacteria like E. coli from the nearby digestive tract to predominate.
That sounds problematic.
It is. This is the physiological reason why postmenopausal women often experience a sudden, frustrating increase in urinary tract infections and atypical vaginal discharge.
But it is not just a chemical change with the bacteria, right? The BMJ and AUA guidelines talk extensively about physical structural changes to the connective tissue as well.
Yes, the architecture changes. Below the surface epithelium, you have collagen and elastin fibers. These are the proteins that give the vagina its stretch, its elasticity, and its resilience.
Right.
Post-menopause, the cells called fibroblasts that produce collagen become dormant. The existing collagen fibers begin to hyalinize, meaning they stiffen and fuse together, and the elastin fibers literally fragment.
Which leads to a severe loss of elasticity, dryness, and a condition called dyspareunia, which is the clinical term for pain during sex.
Yes, it can be incredibly painful and greatly impact a patient's quality of life. The friction on thinned, inelastic tissue can cause micro-tears.
Oh, that sounds awful.
It is, but the clinical guidelines offer a wide array of highly effective treatments. The gold standard is usually local, low-dose vaginal estrogen.
Meaning creams, rings, or tablets that are inserted directly into the vagina.
Exactly.
So it brings the estrogen right back to the specific tissue that needs it without necessarily blasting the patient's entire bloodstream with systemic hormones.
Exactly. Local estrogen essentially reverses the cascade. It pumps the mucosa, brings back the glycogen, feeds the lactobacilli, and drops the pH back down.
That's amazing.
And there are also other localized options, like intravaginal DHEA, also known as prastrone, which the vaginal cells take up and convert into active hormones right there in the tissue.
Wow, just locally.
Yeah.
Yeah.
There is also an oral medication called osbemifene that specifically targets and stimulates vaginal tissue without acting like estrogen in the breast tissue.
I noticed the guidelines also feature non-hormonal options for people who can't or don't want to use hormones, things like hyaluronic acid moisturizers, but also lasers. How on earth does a laser fix thinning tissue?
Fractional CO2 lasers are fascinating. They're used to create microscopic ablations, tiny controlled thermal injuries in the vaginal wall.
So you are intentionally injuring the tissue.
Yes, because it triggers the body's natural wound healing cascade. The micro-injuries cause rush of blood, growth factors, and oxygen to the area.
Oh, I see.
Yeah, it tricks those dormant postmenopausal fibroblasts into waking up and producing fresh collagen and elastin to heal the wound, which restores the elasticity and thickness of the tissue naturally.
That is incredible. And I want to make sure we highlight a crucial note from the AUA guidelines regarding breast cancer survivors, because for those patients, the idea of introducing any estrogen, even locally, sounds terrifying.
It is a very common and valid fear. However, the current clinical consensus suggests that local vaginal hormones are generally considered safe for many breast cancer survivors because the systemic absorption is so incredibly low.
But they should still be careful, right?
Absolutely. It is imperative that this is managed carefully in close coordination with their oncologist.
So, what does this all mean? When you read the dry medical texts, GSM sounds like this terrible, inevitable cascade of structural failures.
It does.
But really, it is just the local ecosystem adjusting to a new climate, isn't it? The rainy season is over, but now we have all these incredibly targeted tools, from localized rings to thermal lasers, to help manage that microclimate so that no one has to just suffer through the discomfort.
That is the essential takeaway. Patients absolutely should not suffer in silence, assuming it's just a normal part of aging they have to endure. With so many diverse options available, the absolute gold standard of care is shared decision-making.
Meaning doctor and patient working together.
Right. Looking at the patient's personal goals, their comfort levels with hormones, and building a custom approach.
It is so empowering to understand the actual mechanics of your own body. We have covered a massive amount of ground today for you. We started with the acidic protective bouncer of the baseline vagina.
You did.
We watched the chemical symphony of estrogen and progesterone open and close the biological gates during the menstrual cycle. We looked through the microscope at the beautiful crystalline fern structures that guide sperm and the thick hydrogel walls that protect a growing fetus.
It's a journey.
And finally, we saw how that entire intricate ecosystem shifts and adjusts during menopause.
It truly is a masterclass in biological engineering. We are talking about a fluid that is constantly reading its environment, assessing threats, and structurally adapting to both protect and propagate life.
It really is. And it leaves me with one final kind of wild thought for you to mull over as we wrap up.
Oh, what's that?
Well, if cervical mucus is this remarkably smart, responsive hydrogel, if it can structurally change its own shape to selectively let helpful things in while simultaneously trapping and killing harmful things out, could medical science eventually engineer synthetic versions of it?
The bioengineering possibilities are staggering.
Just imagine a synthetic mucus coating, one that could be applied to pacemakers or artificial joints to completely prevent surgical infections.
Wow.
Or a synthetic hydrogel you swallow that delivers targeted drugs right through the body's barriers, fighting off bad bacteria without us ever needing to rely on traditional gut-destroying antibiotics again.
That would change everything.
The perfect blueprint for all of this is already right there, functioning silently inside the human body. We just have to be smart enough to learn how to copy it.
It could redefine how we approach infectious disease entirely.
Well, thank you so much for joining us on this deep dive. We hope you walk away with a newfound appreciation for the complex, beautiful, and ever-changing ecosystem of your own biology. Keep questioning, keep learning, and we will see you next time.